So we're going to switch gears a little bit right now, by talking about immigration in the United States, which in some ways is similar, but in other ways very, very different. And before I get to that, I thought I would share the story of my summer in the context of this paper. When Benoit invited me at the beginning of the summer, I was working on several different papers at different stages, all considering the relationship between the availability of immigrant labor and the quality of healthcare services in the United States. So I got the invitation. I think I responded immediately. Absolutely, this is a perfect conference to present this work. Okay. In July, I got the email from Lee saying, can you send the title? I was still feeling really ambitious in July. I thought that I had several different projects to present, and maybe I should include all of them in the title, but I wasn't sure. And so the title that you have in the program is kind of vague, reflecting my ambition in July. Okay, my mother had planned back surgery at the beginning of August. The surgery was planned. The amount of work that I needed to do to help her get around the house and help her do other things around the house, I had not planned. And then a few weeks after that, my father had a fall, needed surgery on his ankle, and was hospitalized, still needs a lot of help, for which my mom cannot help. And all of this is an introduction to say that, unfortunately, I do not have a paper ready for you. This is brand new work. It's not the first time I present this paper because the paper doesn't exist. I'm not presenting the paper. What I'm presenting is some preliminary results that I would love to get your feedback on, and apologies to the discussant. Okay, so what am I talking about today? Immigration policy, specifically interior immigration enforcement policy and the quality of healthcare in home health agencies. This is joint work with my co-authors Abdul Mason Almuhaysin, who is now at the Saudi Central Bank, and Catalina Amoedo Dorantes. Okay, so I don't need to motivate immigration very much at this conference. I actually don't think I need to motivate the importance of immigration anywhere in the world right now. It's of central importance in the US presidential election. Trump has vowed to carry out the largest domestic deportation operation in American history. Harris, who is more immigration friendly, has highlighted support for a failed bipartisan border deal, which would have increased funding for border agents, detention facilities, fentanyl detection technology. All of these things very different from the kinds of discussions that you have in Canada. At the same time, Vice Presidential candidate J.D. Vance has repeatedly expressed concern about population decline in general, and particularly declining birth rates in the United States. I'm not so partial to his comments on childless cat ladies, but he is absolutely right to be concerned about aging in the US population. So here we have a few age distributions in 1960 and 2060. So in 1960, you could see that we had, and this is not special for the United States, it's true of most developed countries, a population pyramid with a lot of people at the bottom of the age distribution and very few people at the top of the age distribution. So the good news is that there are very old old people needing care services, a lot of working age people that can provide those services. Fast forward to what we expect to happen in 2060, and the slide says the population pillar. When I looked at it this morning in the context of my summer, it looked like a population brick being thrown at us. It's just flat. And so there are a lot of people needing help, and it's kind of one for one with the working age population. I hope that health continues to improve over the years, but about 2/3 of people above age 85 have some difficulty with ADL, so activities of daily living, things like eating, bathing, and dressing. Most of this care is provided informally by friends and family members. About 40% of these people needing care get this care, get formal care either in the form of nursing homes or skilled nursing facilities or home care services. Home care is expensive. It varies across different places. Most of this, it depends on wages, which is the biggest chunk of the cost in Rhode Island, where my parents live. We're in the top 3 most expensive places. I know it's hard to see, but you can think about this, at least in the most expensive places, as about $6,000 per month. A lot of people need this throughout the year. It's a lot of money. Home health care expenditures have been increasing quite substantially. It's not that we all of a sudden are spending more money on this for no reason. The reason for the increases is that Medicaid, which is the healthcare insurance for people in poverty in the United States and also the biggest payer for nursing homes, has realized that nursing homes are quite expensive relative to paying for home care services. And so slowly, state by state, Medicaid has become more and more generous in terms of paying for these services over time. It's not guaranteed, so you're guaranteed that Medicaid will pay for nursing homes if you need that type of help. You're not guaranteed home health. What is a major issue for even people who can get help with Medicaid or want to pay for home health services out of pocket? Staffing shortages. These staffing shortages were all over the news during COVID. They remain an issue. Just to give you a sense for the headlines, home care crisis leaves New Yorkers without aides, and families face burnout. Seniors are stuck home alone as health aides flee for higher paying jobs. Okay, looking to the future, home health is a very fast growing occupation in terms of numbers, it is the fastest growing population for the coming years. Also, it's an occupation in which immigrants are overrepresented. So in the United States, immigrants comprise about 13-14% of the labor force, but more than 30% of home health aides are immigrants. Surprisingly, a little bit less for personal care aides, about the same for physicians.
What's the difference between a home health aide and a personal care?
Personal care helps put people to bed, helps wash them. Home health, they actually provide some sort of health service. So they could check your blood pressure, for example. It doesn't have to be super high skilled. What they can do depends on different state laws regarding the licenses that you need to do different things. In certain states, you even need a license to give someone a Tylenol. Yeah?
Very quick question also. So who's their employer? Is it the government through Medicaid?
Okay, so this is just by occupation, and their employer could be personal households. I could pay someone to come to help take care of my parents. Home health agencies are often paid for by either Medicaid or Medicare. In situations like my father's, he had surgery, and so when he came home, Medicare, the health insurance for elderly people in the United States, pays for people to come into the house. Most of the people that have been coming to my parents' house are doing physical therapy as opposed to cleaning the house or making food or anything like that. But that would depend on the situation. Other questions? Okay, so there has been work in general looking at the relationship between immigrant inflows and elderly care. Most of this work has used the empirical techniques that Fang used in the presentation that he gave yesterday. What do we know? When there are more inflows of immigrants into an area, You can think about this more inflows into a city. This tends to reduce the cost of services, things like housekeeping, gardening, personal care aids, etc. And there have been papers that have found this. It has been found to delay older women's retirement age. So many women who would otherwise leave the labor force to care for parents or a spouse can remain in the labor force if they can find immigrant labor to help with their caregiving responsibilities. Places with more immigrants means that when parents are hit with a health shock, children can remain in the labor force. In my own work, I have shown that nursing homes that happen to be in places with more immigrant inflows see improvements in the quality of care they provide, as measured by things like the percent of residents that have fallen in the past few months, or the percent of residents that have pressure ulcers because they weren't moved around in and out of bed sufficiently. Okay. Other work has shown that in places with more immigrants, elderly people are less likely to move into nursing homes. Again, because it is easier to find people to come into the home to help take care for the elderly. So we contribute with this work to this literature in two ways. First, we're the first paper to look at this specific industry of home health. And second, instead of looking in general at the relationship between immigrant inflows and the quality of care provided by home health agencies, we are looking at a specific policy, which you might not even think would have an impact on the quality of home health, but I'll show you that it might. Okay, so I hear that in Canada, interior immigration enforcement is not really a big issue, but in the US it is. So ICE has a budget which has more than doubled since its inception after 9/11. Their budget is similar to the budget for the FBI and almost quadruple the budget of the Drug Enforcement Administration. So it's a lot of money, it's a big deal, a lot of resources go into this. The number of people deported annually roughly doubled from the early 2000s until 2014. To give you a number, I understand that it's rare to have any deportation in Canada. So just before this talk, I looked. As a result of the specific policy that I'm studying today, 454,000 deportations occurred in a very short period of time between 2008 and 2014. So yes, the number of undocumented immigrants in the US also increased in this time from 9 million to 11 million, but nowhere close to the rate of deportations. So let me tell you a little bit about this particular policy that we're studying. Secure Communities is an information sharing policy, and the goal was to facilitate the identification and removal of non-citizen criminals. So it was gradually activated in US counties starting in 2008. Full activation in the entire United States had been reached by 2013. And the way that it works is the following. It only directly impacts people who have been arrested in the United States. And so when you're arrested, your fingerprints are taken, and that information has always been shared with the FBI to see if you're wanted for some serious crime. However, as a result of the Secure Communities policy, if there is a violation of immigration law, then ICE is contacted and the local jail has to keep, by law, those people locked up until ICE decides whether to come and pick these people up, potentially to start deportation process. Okay, so this program was suspended at the end of 2014, reactivated in 2017 when Trump was president, suspended again in 2021. In practice, ICE is still getting the information, and so deportation can still happen. So the intention of this policy was to remove, like I said, non-citizen criminals. But because so many people were deported, again, the information was shared for anyone who was arrested. So if you happen to be arrested because you happen to be at the wrong place, at the wrong time, even without doing anything wrong, your fingerprints were taken and this was shared. And so many of the people who were deported because of secure communities hadn't committed any crime at all. Most of the people who were deported either hadn't committed crimes or were not convicted of any crimes, or they were convicted for very low-level crimes. And driving without a license can be considered a crime, even though if you're undocumented in many states, you're not allowed to have a license. Okay, so perhaps unsurprisingly, there were a lot of harmful consequences on the undocumented immigrants in the United States and their families. We focus on an unintended consequence of immigration enforcement on a particularly vulnerable population, Americans who require services in their homes because of their age, because of a disability, or, like my father, short-term recovery after a hospital stay. Okay, so let me give you a little sense. This is a small sense of the literature. Perhaps not surprisingly, given that you don't know when these deportations would happen, it was difficult for me to find exactly what the secure communities policy was doing. Probably a lot of ambiguity, a lot of fear among the undocumented immigrants who it might not be so easy to read about these policies. There's evidence that it increased mental health distress among Hispanics. It reduced participation of citizens who should not be concerned about their own deportation. It reduced participation of Hispanic citizens in welfare programs that they were entitled to. Arguably, or the authors argue, because people were so afraid to have anything to do with anything related to the federal government or any government service. The policy is associated with decreases in educational outcomes among Hispanics. I have here, and more importantly, I don't want to argue it. It's just more important for my particular topic. There's a lot of evidence of decreases in the labor supply of housekeepers, childcare workers, home care workers, home health care workers. Again, mostly because these people were afraid. This has had downstream impacts on all Americans. There's evidence that college-educated, native-born American women became less likely to work or less likely to work as many hours because it made it more difficult for them to find childcare workers, housekeepers, nannies to help them around the house or care for their children while they go to work. My own work with my co-authors, we have shown that this policy has increased the likelihood that the elderly move into nursing homes, again, because it's difficult to find someone who might be undocumented to come to your house and take care of your elderly parents or a spouse. There's new work showing that the Secure Communities policy reduced the use of childcare centers, presumably because of these labor supply shocks. So we contribute to this literature by looking at the quality of care provided by home health agencies. And this is important because home health agencies probably do not hire very many undocumented immigrants. Okay, so part one of the paper, how has secure communities affected the quality of care provided by these home health agencies? I've already talked to you a little bit about this. What are home health agencies? They provide part-time healthcare services in people's homes. What happens is that these services are often ordered by a physician treating a patient after an illness or an injury in the hospital. Examples of services: people will come to your house, check your blood pressure, temperature, your heart rate. They assess the safety of the home. The person coming in yesterday was going to teach my father how to bathe in his own house in the bathtub safely. And they also confirm that patients are correctly taking prescription drugs. They educate patients and their caregivers on the importance of proper nutrition and exercise. A lot of them do provide physical therapy and occupational therapy. Now, some of these agencies do provide housekeeping and personal care services, but in order to be reimbursed by Medicare, they must also provide skilled care services. They need to provide services that would only be provided by a nurse, for example. Medicaid can pay for long-term personal care services, but again, eligibility for Medicaid depends on the state. So a lot of these agencies are paid for by Medicare, and so they have to provide some sort of skilled care. Okay, so what are the theoretical considerations? Again, secure communities mostly impacts people who are arrested, who are overwhelmingly, almost all male. 96% of the deportations were male. Meanwhile, people working for these home health agencies are overwhelmingly female. So it's unlikely that the secure communities policy is having any direct impact on these home health agencies at all. You might not expect anything. It's probably what I expected to begin with, but it's possible that there was an impact. And even if there was, it's unclear in which direction. I've already told you a little bit about my own work finding that as a result of secure communities, people can't find the most likely the often undocumented immigrants to come into their homes to do housekeeping, cleaning, feeding, bathing the elderly people. This made it more likely that Americans moved into nursing homes. Now, if they're in nursing homes, they're not getting home health agency care, and so you might expect less demand. There are more workers per people. These agencies can take more time with their patients. This would improve quality of care. It could also be that the undocumented immigrants are apprehensive about having anyone that they don't know in their house. Again, a decrease in demand, and this may, again, improve the quality of care provided by these home health agencies. It's also possible, however, that if there are labor supply shortages in these home health or among home health workers, if there aren't enough people to work in these jobs, the quality of care could suffer. And there's different reasons for this. It could be that even if the women who are working in these jobs are not being deported, their husbands could be deported, and so they could go back to their home countries. It could be that people feel nervous, especially in this job, which requires a lot of driving from house to house, to be exposed in this way. And so maybe they still work, but perhaps for fewer hours, again, leading to labor supply shortages. It could also be labor market spillovers to native workers that are not Hispanic and have nothing to do with the secure communities policy. But if there are openings in other sectors where there's a lot of movement out of the labor force by the undocumented immigrants, and so people who might have otherwise worked in these home health agencies take these other jobs, and again, we end up with labor shortages. All of these are possible. Let me tell you about the data that we have on home health quality. It's provided by CMS, the Center for Medicare and Medicaid Services. Not a lot of information in this data set. We have the types of services that are provided: nursing, physical therapy, occupational therapy, medical social services, and home health aid services. So these are the people that don't have nursing skills. We can also tell whether these agencies are for-profit or not for-profit, which we've learned is quite important. And importantly, we have quality measures. For example, the percent of patients that get better at various activities, things like walking, bathing, taking medications, etc. The specific measures of quality that we use are those that are available in most years. So things like the percent of patients who get better at walking or moving around, who get better at getting in and out of bed, moving around, who have less pain when they're moving around, get better at bathing, get better at taking prescriptions, and perhaps most importantly, the percent of patients who get readmitted to the hospital. For our preferred specification, the only specification that I have for you today, we standardize these measures, take the mean, and use that index as our measure of the quality of care provided by these home health agencies. We get additional data from the provider of services files, and this has information for each healthcare provider in the United States, the universe of providers in the United States, the county that the provider is located in, the number of workers in each occupation, and a whole bunch of other things. We haven't used these other things yet. And then other data was downloaded mostly from one of those other papers that look at the impact, was downloaded from the replication files of one of those other papers that look at the impact of the Secure Communities policy. And so this gives you an idea of the variation in terms of the year in which the Secure Communities policy was enacted in the different counties across the United States. You may look at this and think, well, a lot of them that adopted the policy early, perhaps not surprisingly, are along the Mexico border. That is true. You may be concerned by this. In robustness checks, we drop all of those counties that adopted secure communities in that first year in 2008. But if you look at you're gonna look. If you look at Florida, you can see a lot of variation within the state in counties that are bordering each other. And the reason for that variation is technological. Some counties had the necessary technology to easily share these fingerprints with ICE, newer computers, I guess, and others were not ready for that. So those that were late in adoption, it is arguably mostly because of technological issues. This was a federal policy. It wasn't enacted in different years in different counties, a federal policy that just took a while to implement because of technological issues, especially when you don't count those at the border.
Sorry, did it require a political decision at the
No.
county level?
No, it was the police department. Can you share this information with ICE? It's a federal policy. Eventually you'll have to do it. Do it as soon as you can. And that led to that variation. Now, the fact that there's so many dark 2008 implementation counties on the southern border suggests that those had the will to get that technology ready to go as soon as possible. But outside of that southern border, it's been argued, not by me, but I will argue it too, that it was a technological issue. And I don't have this for you, but the other papers have shown there's no relationship between the date of implementation and trends in those counties before. So it's not that the trends that were growing in the Hispanic population that were especially likely. Housing prices had some impact, but as you would expect, there's a bunch of them. I can direct you to those papers. Okay, so the estimating equation is nothing super exciting. Our outcome variable of interest is the index of quality provided by the Home Health Agency P, located in County C, observed in year T. And so the right-hand side variable interest is a dummy variable, SC for secure communities, equal to 1 if this policy was implemented in January of the year T. We have a vector of county year level controls. In the specifications that I will show you today, we control for whether there was a 287 agreement, which was a stronger immigration enforcement policy, E-Verify policies, Bartik controls, share of the county population that is over age 65. The Bartik controls are just a way to get at labor market conditions that in a way that would not be affected directly by the Secure Communities policy. In all specifications, we have provider fixed effects, so we can observe the same home health agency in different years, and we're controlling for things about that home health agency that stays the same across the different years. And we have quarter year fixed effects as well as an error term. So here's the baseline finding. If we look at all of the home health agencies, there is a negative relationship between secure communities implementation and the quality of care provided by those home health agencies. Admittedly, the estimate is quite small. It's about 1%. But given that it's not clear that we would expect any impact at all, given that these agencies probably hire very few undocumented immigrants, I think it is quite telling. All of this is driven by the private home health agencies that tend to be of worse quality. Okay, so if you're concerned about bias from staggered differences in differences, we did the Bacon decomposition, and the good news is that almost 80% of the identifying variation is good. The results are robust to using the Gardner correction. It just takes a super long time for the code to run, and so you're not seeing those results. Although I have it if you'd like to see it at the end. We did some event studies. This is not exactly corresponding to the provider fixed effects specification, but we have county fixed effects. And if you look at all home health agencies, it looks like there's something going on after the implementation of secure communities. It's a lot more clear if we focus just on the privately owned home health agencies. So the conclusions regarding home health agency quality is that secure communities is associated with not improvements in quality, reductions in the quality of care provided by home health agencies, especially the privately owned agencies. Given this, most likely the driving force is labor supply or decreases in labor supply for some reason or another. And so the second part of the work is to look at whether secure communities affected home health labor markets. And for this part of the work, we look at data from the American Community Survey, covering 2006 to 2014, working age population. And here the main outcomes are number of workers, hours of work among the workers, separately by education and race, ethnicity. One difficulty is that while we can identify the county for each home health agency, in the ACS, we cannot identify county. What we can identify is public use microdata area, PUMA. PUMAs sometimes lie completely in one county, but sometimes there are PUMAs that lie in two different counties. Most of these PUMAs are in counties that enact secure communities at the same time, but sometimes they don't. And so what we do is create a continuous version of this secure communities policy, which is actually the fraction of the population in the PUMA that is, or the fraction of the population of the PUMA that is in a county that has adopted secure communities. Okay. All right, and so it turns out that, so with these data, we can see that immigrants are overrepresented in the home healthcare sector using the industry variable in the ACS. I was surprised that 20% of the people that work in the home health sector in health-related occupations are foreign-born, while they only represent 15% of the labor force. Even if you look at undocumented, which I thought, or not undocumented, likely undocumented, and I say that a person is likely undocumented if they're low education and they are from Mexico or another Latin American country. Not a perfect measure, but it's really close. The people in this population in the home healthcare sector versus all other sectors. The other thing that I was surprised about, a lot of the people that work in the home healthcare sector are working in low-skill occupations. So the support services, the nursing assistants, as opposed to the nurses, the personal care aides. Okay, estimating equation is almost exactly the same as the one you just saw. Instead of home health agency fixed effects, we have PUMA fixed effects. And I've already described the secure communities variable. And so if we look at the total number of workers in the home health sector divided by the total population in the PUMA, divided by 100, and we look at all occupations, we see that there is indeed a decrease by about 6% in the number of workers. If we zero in on the low education support occupations, this is driven by Hispanic workers. So we see a 17% decrease in the number of Hispanic workers, nothing for non-Hispanic whites. However, if we look at all occupations and just focus on white workers who you wouldn't think would have an effect, there's a decrease in the number of people, there's a decrease in the number working in this sector. Similar relationships if we look at hours of work instead of just number of workers in these different occupations. And we also look at wages, because if it is a labor supply shock, we should expect an increase in wages. This is not a perfect measure because wages are not just equilibrium, are not reflecting just the equilibrium wage, but also who stays in those jobs. Are they the high wage people or the low wage people? But I think it's telling that in general we see, or if we see a statistically significant impact, that impact is positive. And so my interpretation is that secure communities is associated with decreases in labor supply at both the extensive and intensive margins, especially among low education Hispanics in support occupations within this industry. There's some evidence that the wages have increased, suggestive of a labor supply shock as opposed to a decrease in labor demand. And so my conclusion is that the implementation of secure communities has led to decreases in the quality of care provided by home health agencies, specifically those that are privately owned, where we might not expect to see any impacts at all. This is consistent, or we provide evidence that is consistent with decreases in labor supply as the primary mechanism. Again, decreases in employment and hours of work, some evidence of increased wages. And so I'd like to end by saying that as Medicaid is funding more and more of these home health services, maybe it's important to keep in mind that similar immigration enforcement policies may end up increasing the cost of these policies that tend to be popular, especially if they are not accompanied by more legal paths to immigration to the United States. On top of this, so that makes it more expensive for all taxpayers, for the elderly that need long-term care services, deportation policies would have a direct impact on the likelihood that they end up in a nursing home, which tends to be their least preferred option. And that's all I have for today.
So the task that Delia gave to me was actually an interesting one, which was, and I would like first to make some comments on the analysis that was actually presented, but I think Delia asked me to branch out a little bit more to what could be done or what would be interesting policy questions at the intersection of immigration and healthcare. So I'll come back to that bigger point where I prepared slides, but just on the presentation and the analysis, I think there are two interesting questions to ask on how to use those results to understand bigger questions. And the first one is, I think I'd like to know a little bit more. You clarified already that SC could have various effects on the immigrant population already present in the state, but also the inflow, the outflow, and so on. So I'd like to actually see some analysis, perhaps using more the population data, just for seeing actually the people present, the immigrant presence in these regions. How do they change as a result of SC before looking at the labor supply impacts, employment impacts, and so on? because there are various ways to interpret changes in employment rates. It could be because Exactly. First, looking at that and seeing how that composition is changing before we get to the labor market to sort of find out a little bit the mechanism. Because as you said, when you first look at what ICE is doing, it's mostly male people they're deporting. Female workers are working in that sector. So obviously, there's a lot of different mechanisms we can think about, and maybe just the population data, which I'm sure you can get, would shed a lot of light on that. That's important because when we come back to Kristen's talk, we want to understand this delta I, this change in population or potential labor supply. We want to know what it is, and here we'd like to know what SC induced in terms of population or potential labor supply change before looking at the exact effects on labor supply and then quality of care eventually. The second thing, which I had not noticed when I looked at your slides, but you went over the slide on the event study. Clearly, you can see that things start going down before the announcement of SC quite a bit. So I can put back the graph, but on the quality of care index, you could see that quality of care started. Most of the decrease that you see exposed is actually happening at T-1 and T-2 on the graph. So you might want to think about that, think about what's happening there, and see, if there are, obviously the threat to identification here is that SC is being implemented in these regions, but there could be other policies at the same time that are being implemented. So we just want to know what they are, or maybe some anticipation effect that maybe ICE is going to be cracking down on in these regions. Now coming back to the bigger issue, so very nice analysis, and I saw you have I encourage everyone to go see Delia's work, the various papers she has written on this particular interaction between immigration, nursing homes, institutionalization, and so on. There's a whole series of very nice papers to look at. On the bigger issue, when I try to think of this big policy problem that is coming up, the shortages in healthcare that we see everywhere, in particular in Canada, and in home care and nursing home care with help with limitations in activities of daily living. So these are workers typically we refer to as PSWs, Arthur Sweetman's favorite acronym, I think, that he uses all the time, personal support workers. And really that problem is really acute. Future shortages, and I'm just going to show you some figures he produced for Canada on the next slide, and you're going to see there's this huge demand coming up in terms of workers. When you see that, obviously medium term, you have various policy options in particularly a publicly funded and operated system, which is to increase the wages of those workers to make sure supply follows demand. That's constrained by public finances and various other considerations, but in a private market, if this was a purely private setting, we would see relative wages simply adjust, and here we go, and potentially people want to do these relatively unpleasant tasks because these are not, I would call, fun jobs to hold, or at least the people who do this are very dedicated. You could improve work conditions. This is a major problem, at least in Canada. One of the biggest difficulty with recruiting people is actually the work conditions. If you think of nurses, home care workers, nursing home workers, so you can work on that. That's going to be costly, but potentially help you face that future demand. So again, it depends on our social willingness to pay for taking care of the elderly, and if it's there, then we should put the money where our mouth is in terms of services required. We could recruit from other occupations. So provincial governments have been all over the place since COVID on that, at least in Quebec, offering these premiums to attract people as PSWs. And then they found out that when they did that, they got a bunch of people who were working in hospitals to change and then go there, or people who were working in close substitute occupations, in education services, in childcare services, that suddenly were moving to these occupations because of these premiums. So now you're basically shooting yourself in the foot. You're not helping. So that also has a limitation, but there's a lot of potential work there to be done in terms of finding what are the right groups to target to recruit them in those occupations. And then the last one is immigration, obviously, which we could use in principle to attract people, particularly in some of these occupations that are less regulated, not talking of nurses, but talking of PSWs and so on. So the United States, definitely a lot of immigrants are working in that sector. It's very similar in Canada. I'm going to show you some numbers. But demand is on the rise for PSW in Canada. These are numbers from Arthur and co-authors from sort of 77,000 workers in the whole care sector, and then increasing nationally, almost doubling over the period. 35% of those workers are immigrants. So clearly there's a nice nexus to study there. And potentially, I haven't seen the breakdown in terms of these non-permanent workers and so on, permit holders and so on, seeing how many of those work actually as PSWs and so on. That'd be interesting to figure out for Canada. Governments are getting very serious with this idea of using immigration. And so, for example, Quebec, I took this from the webpage of the Quebec government. They've set up actually an agency to go out around the world and get people, basically steal people from various countries and attract them in various occupations, including in nursing. They had a program for PSWs where they tried to do that, and it was very unsuccessful. They didn't manage to get a lot of people. Think of this as you go out to a country and you tell people you're going to be coming here to work for $15, $20 an hour, and you're going to be wiping, people's bottom and so on, and that's going to be your job. Do you want to take it up and come over? So that didn't work. That didn't work really well, which maybe suggests, which would be interesting to study, that maybe a lot of the immigrants working at PSWs, that may not be their dream job or the job they're qualified to do, but they end up doing that because there's really nothing else. It's creating a lot of pressure because every government's doing that, trying to recruit, and particularly in less developed countries. And for example, for Quebec, we have the language issue, which is a big one, where we can't go easily to India or China to get PSWs because they need to speak French. The elderly in these houses are mostly French-speaking. And so we go and recruit in Morocco, Tunisia, countries like that. And that creates sort of an interesting econ or philosophical ethical problem, because if you look at the state of these healthcare systems in these countries, we're basically going and getting or stealing these nurses or giving them very interesting conditions in places where basically nurses per population is very low. So systems that are struggling, and it's actually creating diplomatic problems where I was reading the Moroccan government and the Tunisian governments were pissed off at Canadians for coming and making offers to their workers. So think of this globally as a more general problem. We have all these developed countries that are aging. They're all demanding these workers in tremendous numbers. Now they could be investing obviously in work conditions, in technology, in other things to actually solve their own problems, but instead they're going to these developing countries and getting those workers. Potentially fair game, it's free market and so on, but on some level it seems like long term, if we all do that, it's going to be very hard to get those resources. So I think an emerging policy issue is that I think it will be very hard for us to really rely on immigration as a solution in healthcare. We have lots of work to do in our own backyard, I think, in particular with wages and work conditions. Obviously, it's going to need some cost, but it seems like there is a demand for those services, so we should be able to do that. Now, technology is also a very interesting aspect, which I had to study in the last few years, where my mind was blown in terms of what is being done in that field. And there are, for example, these living labs now that have been put in place where in your apartment, for example, in a private home where you're fully autonomous in principle. Basically, they put various devices in your apartment to help you remember to turn off the water, remember to eat, remember to do various things. And that, in principle, there's a lot to be done there. And they show that it basically delays entry into nursing homes or the demand for home care. So it seems there's a lot we can do there. I think it's a recurring policy issue, and it's very similar to the one we face in other industries. It's governments are trying to find the easy way out, recruiting cheap labor in order to provide services, a bit like firms do as well, in terms of avoiding to do the capital investments or the necessary changes that they need to do. The non-permanent residents that we have currently in Canada may at some point, given the bottlenecks that Mikhail talked about, become undocumented. And so the situation you studied, which seems very far away from what we go through here, potentially, if we continue on this path, we could end up with similar difficulties or trade-offs where if we crack down on the undocumented that are now working in healthcare, we face these trade-offs that we really don't want to, we'd like to avoid medium term. Okay, so I'll stop here. Thank you.